Welcome to Nourish MD, Doctor Dietitian Dialogues, where doctors and dietitians empower you about your health and discuss and provide a better path to health and wellness. Proudly presented by Concierge Medical Practice Private Physicians Medical Associates, PPMA, with your hosts, registered dietitians and nutritionist, Lauren Papanos and Romana Brennan.
Hello, everyone, and welcome to Nourish MDs. I'm one of your hosts, Lauren Papanos. I'm one of the registered dietitians. And today we are going to be talking with Dr. Quist. Some of you may know him. He is one of our specialists, a gastroenterologist that we refer to often. And we're really excited to have him on the show. He's going to be really walking us through understanding more about GERD and reflux, heartburn, some of these nagging symptoms that you may be experiencing on a day-to-day basis. So thank you so much, Dr. Quist, for being here, and welcome to the show.
Hi, thank you, Lauren. Thank you so much for inviting me to talk on this extremely important and common problem.
Yeah, absolutely. I think that it'll be a really good discussion just to really ease the concerns and questions that come up for a lot of patients that are experiencing GERD, or maybe don't even know that it's GERD, but experiencing discomfort, right? So could you just start off and give us a bit of an introduction into yourself and your educational background, your practice, any of that information that could be valuable for us to know about?
Yeah, certainly. So I'm a gastroenterologist. I'm in private practice in Newport Beach. I've been practicing since 2001. I practice out of Hoag Hospital and the Hoag Endoscopy Centers. I did my GI training at University of California in San Francisco.
Awesome. Wonderful. And I know, like I said, that we have had several patients that have been referred to you over the years. And so you've been a great referral partner for us. So thank you for that. And, let's just kind of start off by really setting the stage and maybe just providing a little bit of a background into what causes acid reflux, what really is happening when someone is experiencing acid reflux, and just more of the background that you see as a physician.
Yeah, absolutely. So first of all, acid reflux is extremely common. It's one of the most common reasons for a patient to see their primary care doctor. It is the most common problem for a patient to see a GI physician. It is estimated about 300 million prescriptions per year are written for acid blockers across America. And if you look at the U.S. population, about a third of the U.S. population is treated for acid reflux during their lifetime. So this is extremely common. The other thing to think about is that acid reflux can occur even in the absence of heartburn, and disease outside of the stomach and esophagus can occur. So there are some other conditions that acid reflux can be attributed to, and it's not uncommon for me to get consultation requests for people who have chronic cough, asthma, and problems with their voice or vocal cord changes, or chronic throat pain, which can all be caused by acid reflux.
Okay. And so you mentioned that heartburn and reflux aren't necessarily one and the same. Can you tell us why they're not the same?
Yeah. So when we think about, what causes acid reflux, you really want to think about your anatomy and some of the structures in the esophagus that prevent things from refluxing into the esophagus. There are really three things to look at. The first and most important is that lower esophageal sphincter valve, that little band of muscle that is in the lower esophagus that opens and closes when we eat. Very important for keeping food in the stomach. The second structure is really your diaphragm muscle, which is that band-like muscle that separates your chest from your abdomen. And what that muscle does is it keeps your esophagus in place and it keeps that valve intact. The third and probably the least important structure is the upper esophageal sphincter valve, which kind of prevents things from going up into your mouth or, into your trachea, your airway, or your vocal cords. So impairment of any of those three structures can be a cause of acid reflux.
And
So when we think about, what is happening during acid reflux, I think we can think about, well, what causes the lower esophageal sphincter valve to become incompetent or to open? And by far, the most common thing is the quantity of food that somebody is eating at once. And so you can eat anything. And if you eat enough of it, that is going to push open that sphincter muscle and allow things to reflux up into the esophagus. Certainly, there are certain foods which are known to relax that muscle. And these are kind of your typical, higher acid foods. So things like coffee and chocolate and tomato sauce and onion and garlic and things that are deep fried are really going to cause a relaxation of that muscle and allow things to reflux in the esophagus.
And common.
The other thing that I wanted to mention in terms of anatomical structures with regards to the diaphragm is that some people develop what's called a hiatal hernia. And the most common cause of this is typically weight gain, or somebody who has gained weight, significant weight in a short amount of time, or are persistently overweight. That weight kind of pushing on your upper stomach pushes your stomach above your diaphragm and creates what's called a hiatal hernia. And that's really important because if you don't have the diaphragm intact, that will lead to things refluxing up into the esophagus very easily. It renders that lower esophageal sphincter valve incompetent when you develop a hiatal hernia. And this is an incredibly common problem. And so that's why when we think about treatment, or when we think about our approaches to acid reflux treatment, weight management also plays an important role. The sauce, all of those things, but also to think about how much food you're eating at once and to listen to your body. And when you're full, to stop eating when you've reached that point to where you're no longer hungry, that you stop, even if it tastes really good, because eating a very large meal is going to precipitate acid reflux in many people.
Okay, that makes sense. So maybe you can clear up the confusion for us. There's kind of, I feel like, two camps here where, some individuals believe that GERD is caused by low stomach acid, and then others believe it's caused by high stomach acid. The low stomach acid being that maybe there's not enough stomach acid to break down that food, and that's why, things are starting to ferment and cause some of this reflux that happens. Is there one? Can you clear up that confusion for us? Does it depend, or is there a unanimous decision between both of those?
Sure. That is a great question, and I get that quite a bit. So certainly acid is present in the stomach. It's a normal part of our digestion. It has mostly antibacterial effects when we eat our food. There are certain components of acid in the stomach that aid certain vitamin absorption. It is a necessary part of our digestion. It's not necessarily high acid or low acid. We know that most people, make acid in the stomach. And if you're refluxing acid up into your esophagus isn't used to that. And that's when you get inflammation, which can lead to chronic disease, heartburn, and symptoms of acid reflux. And that is why the proton pump inhibitors and acid blockers are very effective, used short term for acid reflux symptoms and heartburn control. So there are some people, and this can be typically older people, where their stomach isn't making as much acid as they used to. And they are still having symptoms of heartburn. And so you have to think about, well, what is causing those symptoms of reflux? Is it acid? It may not be. It could simply be stomach contents or bile. And there is something called bile reflux, which is treated differently than acid reflux. And so when we're undergoing our evaluation, we do testing with biopsies, and we're actually checking to see if patients have more acid reflux or bile reflux. So that can be treated differently.
Interesting. Okay. That's great to know. And I think, provides a little bit of hope for some patients that maybe are in that camp, like you mentioned. I think that there's some kind of hidden signs of heartburn or reflux that can happen too, that maybe aren't as apparent to patients. Maybe it's not just happening after they eat a meal. Could you outline what some of those are that you see in practice where you identify this is GERD, but maybe they don't present with the common symptoms of GERD? Interesting.
Yeah. So I think that when we see patients who have issues with asthma that is difficult to control, where they may not be responding to their inhalers, we will frequently get consultations from the pulmonary doctors or the primary care physicians that could this be acid reflux related? And there are up to 20% of people with asthma that it is entirely due to GERD, and that can be even in the absence of heartburn. So other things could be like somebody with a chronic cough, or they may notice that they are coughing during their meals or coughing after they're eating. And that is maybe due to acid reflux, even if they're not having heartburn. And so it's important to keep that in mind, and also issues with throat pain, vocal cord changes or loss of the voice, that these all may be things due to acid reflux. So for those patients, we do recommend a further workup. We will do an endoscopy. We can look and see if there's signs of esophagitis or inflammatory changes. Sometimes we will place a little pH monitor in their esophagus that it kind of has a little suction device and sticks to the wall of the esophagus for about 4 or 5 days. And it is continuously measuring how much acid is coming up into the upper esophagus and whether or not that is triggering a cough or problems with their voice or problems with asthma or their breathing. And that can be a very useful study because that is defining whether or not there's acid reflux going on and whether or not it's correlating to their symptoms that they're having in the absence of heartburn.
Interesting. Is that uncomfortable for that suction cup to be there for a couple of days?
No.
Okay.
It's really small. It's like the size of a small pill. And when I do the endoscopy, I just place it and it sticks to the wall for about 5 days. And it's wirelessly measuring the acid level. And it's transmitting that to a receiver that's kind of like a cell phone that they carry with them for the study duration. At the end of the study duration, it comes off on its own and it just passes in the stool. They never see it.
Discover the wellness you deserve. At Private Physicians Medical Associates, PPMA, you'll receive personalized premium preventive care and one-on-one medical attention with an emphasis on prevention, nutrition, and wellness. Extended office visits, appointment availability, 24/7 physician access, limited patient enrollment, PPO insurance and Medicare accepted. This is concierge medicine. This is medicine the way it should be. Call today for a free consultation at 949-566-8179.
Okay, so you mentioned some of these symptoms like asthma, maybe breathing difficulties, the coughing, obviously heartburn that could happen with GERD. Is there any other symptoms that when someone has GERD often go hand in hand where you see, okay, once they're now managing the GERD better and maybe their symptoms are under control, other symptoms improve? I'm thinking things along the lines of like headaches or joint pain or nutrient deficiencies, hair growth, things of that sort.
Mhm. Yeah, those haven't been associated with acid reflux per se as the primary problem.
Sure.
Those other issues. But I would say that when you think about other issues with GERD, such as swallowing difficulties, things getting stuck in the esophagus, problems with recurrent chest pain, or even chest pain with shortness of breath, that many of those are related to acid reflux disease, and those will improve, those symptoms will reverse with proper treatment.
Okay. Got it. And are there any conditions that may precede GERD? And I know this might differ based off of the population or the age of the person, but if you could just provide us if there's a couple that you see commonly happening.
Sure. So, yeah, I think the most common, things to think about that may precede GERD would be patients who are overweight or the obese population. Very common to develop complicated acid reflux. People who have long-standing diabetes, even if it's been well controlled, long-standing diabetes kind of slows your digestion. The stomach may not be emptying quite as well, and that can lead to acid reflux problems, reflux disease. Those are two of the most common. I think more recently what we've been seeing in the office is patients on weight loss drugs. So people who are taking Ozempic or the GLP agonists, Mounjaro, Wegovy, etc. Those work by slowing your stomach emptying and slowing your digestion. Acid reflux is really common with that. And when your stomach is not emptying as frequently, you're not absorbing, so you're not hungry, you're getting full quickly on those drugs, but things are sitting longer in the stomach, so you may be more likely to have acid reflux problems while taking those medications. Changes, and it is a precancerous condition. It is a risk for esophageal cancer. If you have that and you leave it untreated or unfollowed, you are at high risk for esophageal cancer. And so when we look at the esophageal cancer rates over time, in the last 20 years, they've just been growing steadily. And a lot of that is due to how common acid reflux is.
Okay.
Those are things that patients want to think about, how often they're having symptoms, how often they're needing to take acid blockers, and think about what could be the different causes. Certainly, if it's mild symptoms that are infrequent, dietary changes are recommended first. So keeping your meal sizes smaller and avoiding those high acid or trigger foods, like coffee and chocolate and tomato sauce and fast food, and then eating earlier in the evening. So never eating a meal within 3 hours of bedtime is really helpful, particularly for those patients who tend to have nighttime symptoms. So they're waking up at night with heartburn. That many of those patients can be managed by keeping their meal portions smaller with dinner, and then elevating their shoulders over their waist when they're sleeping. So either getting a wedge or that second pillow under their shoulders.
Okay. And do you ever see with patients that when they follow some of these recommendations that their GERD is, completely not an issue for them anymore? Or is it more just about management? And once they've been diagnosed with GERD, it's really just about trying to decrease flares and decrease these uncomfortable symptoms?
Yeah, I think, if patients are undergoing an evaluation and let's say on their endoscopy, they have mild to moderate, inflammatory changes, I might have them work on their diet in conjunction with a short-term proton pump inhibitor, something for 3 to 6 months, maybe a follow-up to show that things are healed. And then we know that things are okay. For patients who are diagnosed with more advanced acid reflux disease, or they have Barrett's esophagus, I'm probably going to, be keeping them on an acid blocker for a while, and thinking about what we can do to reverse that situation with acid reflux. So that might involve a acid reflux surgery or procedure. We have several surgeries or anti-reflux procedures that are available to us now. They're available here at Hoag Hospital, at UCI, locally, for patients who maybe they have long-standing acid reflux disease with Barrett's esophagus and a hiatal hernia, or where they cannot get off their acid blockers. They are really the ones that we're referring for a surgical procedure or further intervention.
Okay. I want to talk or ask a little bit about, I know you do some treatment with things like SIBO, small intestinal bacterial overgrowth. And I'm curious as to, we see a lot that when people have a history of SIBO, have H. pylori, that a lot of times the heartburn improves when those get treated. Is that what you see? Is there correlation? Could you explain a little bit as to what's going on there?
Yeah, absolutely. So, SIBO is really evolving into a common problem and is something that is more and more recognized. There are different types of SIBO. There is hydrogen-producing SIBO and methane-producing SIBO, and there are different treatments depending on what type of SIBO you have. It is a overgrowth of bacteria that occurs in the GI tract. We don't know exactly what causes it. There are certain patient populations who are more likely to get SIBO, particularly the patients with collagen vascular disease like rheumatoid arthritis, scleroderma, Sjogren's disease, very frequently get SIBO. And it can present with just a general upset stomach, belching and burping and indigestion. And when we do an endoscopy, everything is normal. And that's when we start to think about SIBO is, when we do our workup for GERD and we're not finding it, then we will go on and do a breath test. And if we diagnose that, we do treat that with antibiotics, which cut down on the level of bacteria in the GI tract. And about 80% of patients respond to that. Very successful treatment. It can be difficult, but that is something that is very treatable.
Okay. So sometimes they'll come in with symptoms like heartburn, and so you'll rule out GERD, and then that's when you'll maybe suspect that SIBO is the next line.
Yeah, exactly.
Yeah. Okay.
H. pylori, we do check for that bacterial infection when we're doing an endoscopy. We do biopsies of the stomach, which assess for H. pylori. For patients who come into the office and they may have mild acid reflux symptoms, I'll frequently do either a breath test or a stool study to document whether or not they have H. pylori. And that's something that's very treatable. A 10-day course of antibiotics is successful 90% of the time to eradicate that bacteria, and then the symptoms usually go away.
Okay. And do you find that their patients generally present with heartburn as well, that's generally a symptom when there is H. pylori?
The heartburn can be a presenting symptom. It is something to think about. It's not the most common. Usually it's more stomach upset, indigestion, belching, burping, loss of appetite, things like that.
Okay. So kind of similar to SIBO then, it sounds like. Yeah. Okay. Okay. And you mentioned that one of the treatments for GERD is proton pump inhibitors or PPIs. And I know that, in my line that there are some nutrient deficiencies that can happen with PPIs. But I'm curious on your end of things, just really, is it safe for someone? Can you explain to us, is it safe for someone to be on a PPI long term? Is there anything that they should know about or that they should maybe consider when they are on a PPI for GERD?
Yeah, I think that, as I mentioned, the PPIs are very effective for GERD. And so in a way, it's unfortunate that they went over the counter because many patients who have GERD will just stay on over the counter PPIs and not seek medical help. And that's really, not what we want. It is effective and it's useful. It is meant for short-term treatment of GERD. There have been some studies, looking at the duration of proton pump inhibitors that are safe. And what has been suggested most recently for my reading of the literature is, up to 3 years is safe for PPI use. After that is really where we don't know. We think that patients may be at risk for osteoporosis or bone density loss, and that there is some evolving data regarding dementia. But it's important for patients to recognize that these are effective and they are very useful and they're okay to use short term. And so we want them to avoid getting Barrett's esophagus and complicated acid reflux disease, or we want their asthma to be controlled. And so they may require a proton pump inhibitor for a period of time. And that may also involve doing other things in conjunction with that, such as working on diet and weight loss, and then withdrawing the PPI and see how things go.
Sure. Okay. And that's really helpful. Thank you. And, you mentioned that diet obviously impacts this and can help with management of some of these symptoms. And I'm curious as to if there's any other alternative therapies that you've seen to be helpful, whether it's stress reduction techniques or specific type of exercise, things of that sort that, or even, supplemental things that you find to help with management of symptoms.
Yeah. Stress reduction plays a role in so many ways with the GI tract, and especially with acid reflux. And when our bodies are under stress, we tend to eat differently. We may eat more fast food. We may be eating in our cars. We may be gobbling down our meals. All of these things lead to acid reflux and are not good to do. So patients who are under stress, they really need to think about mechanisms of stress reduction and avoiding the things such as I mentioned, and slowing down your meals, avoiding fast food, eating in your car, carbonated sodas, going to bed on time, not having dinner and then going to bed because you're exhausted from work or stressed or tired. And so stress can absolutely play a role in acid reflux. And that's definitely something to think about. Alternative therapies. I think there are some alternative products that are very effective. There's a product called FD Guard that is over the counter that is related to caraway oil, peppermint and caraway oil that patients really seem to respond to who have acid reflux. It's kind of a natural acid reducer. Kind of like an aloe vera product that just works to reduce acid. Very safe to take FD Guard long term, and a lot of patients find it effective for like belching and burping and indigestion and those things. And then I think that the H2 blockers, such as Pepcid, they are safe to take on a regular basis. They usually work best when taken at bedtime, and they're particularly helpful for patients with nighttime acid reflux. So those are okay to use the over-the-counter H2 blockers like Pepcid AC, Pepcid Complete.
Amazing. Yeah, I'm glad you mentioned aloe vera too, because it's one of my favorites for gut symptoms. I find it's really helpful for more like constipation and slow motility type issues as well. And I'm sure if you see that as well.
Absolutely.
Yeah. Wonderful. Okay. This is all great. Thank you. Well, Dr. Quist, thank you so much for all of your knowledge and expertise and what you're doing for patients and helping them, and just your time really sharing this information with us today. Like I mentioned, we already have patients we're referring over to you, but for any new patients that are listening to this that might not be familiar with you or your practice, but maybe would like to schedule a consultation so that they can understand a little bit more about their symptoms that they're experiencing, where can they learn a little bit more about your practice?
Yeah, absolutely. So they're welcome to see my website, richardquistmd.com. You can call the office and schedule an appointment. We have availability. Happy to see anyone. 949-645-8300. And thank you so much for letting me speak today. Really appreciate it. And happy to see anyone and work with you on these.
Wonderful. Thank you so much. And for any patients that are listening that are already a PPMA patient, you can go ahead and give our office a call as well, and we can help you with that referral process. Otherwise, if you're not a PPMA patient, and go ahead and call that number that Dr. Quist provided. Thank you so much, Dr. Quist, and hopefully we'll talk with you soon.
Okay. Thank you, Lauren. All right. Bye-bye.
Thank you for joining us for today's episode of Nourish MD, Doctor Dietitian Dialogues. This podcast is intended for general educational purposes only. It is not a substitute for professional medical advice. Please consult with your healthcare provider before beginning any nutrition or supplement recommendations. Sign up for our mailing list so you'll never miss an episode of our wellness journey. See the podcast description for the link.